Hello everyone. Today we will discuss non-nutritional causes of rickets in this 5-mark short note series. So what is rickets? Rickets is defective mineralization of growing bones due to disorder calcium, phosphate or vitamin D metabolism. Non-nutritional rickets, that is rickets that is not due to any micro or macronutrient deficiencies occur despite adequate nutrition and sunlight exposure. So in this patient, there will be normal levels of vitamin D. Despite having normal vitamin D levels, they will be having rickets. It is usually caused by genetic, renal, or metabolic abnormalities affecting vitamin D activation or phosphate handling. So when you should suspect for vitamin D resistant rickets. So poor response to vitamin D therapy even after 6 to 8 weeks. The patient will be having normal 25 OHD vitamin D but persistent biochemical rickets. There will be a family history of rickets or short stature, presence of renal or systemic features like polyuria, alopecia, or urinemia, and you have to screen them with the serum calcium, phosphate, ALP, parathyroid hormone, and renal function test. So, how the children will be presenting in the clinic? Usually, they will be seen between 6 months to 3 years of age. The skeletal deformities they will be having bowed legs, knock knees, and widening of the wrist. There will be growth failure, delayed walking, and poor feeding. Muscle weakness will be there associated with hypotonia and irritability. In case of renal rickets, they will present with pallor, edema, polyuria, and hypertension in addition to the above symptoms. In case of vitamin D dependent type 2 rickets, there will be alopecia, and in case of RTA, there will be dehydration and acidosis. So, what are the classification and causes to sum it up? So, vitamin D dependent rickets type 1. So there will be a defect in 1 alpha hydroxylase enzyme deficiency. So there will be no conversion of 25 OHD to active 1, 25 OHD. This will result in rickets. In case of vitamin D dependent type 2 rickets, there will be mutation at the level of vitamin D receptor. So there will be end organ resistance to calcitriol. In case of hypophosphatemic rickets, there will be a mutation of PHEX gene or FGF23 mutation, which will result in renal phosphate wasting and low serum phosphate. Renal rickets, there will be chronic renal failure and decrease in the level of 1 alpha hydroxylation phosphate retention acidosis. Renal tubular disorders, there will be RTA or Fanconi syndrome and urinary phosphate and bicarbonate loss will be there. In case of calcium metabolism disorders, hypoparathyroidism, pseudo-hypoparathyroidism will be there. There will be low or resistant to parathyroid hormone, which will result in hypocalcemia. Clinical features include generally they will be having growth retardation, bone pain, and delayed milestones. In case of skeletal, there will be craniotabes, frontal bosoning, widening of the wrist, genu varum or valgum, then ricketary rosary will be there. There will be hypotonia and waddling gait as neuromuscular presentation. In specific causes, there will be specific systemic signs like in alopecia will be there in vitamin D dependent rickets type 2, polyuria will be there in RTA, and pallor, edema, and hypertension will be associated with renal rickets. So coming to the investigations. So serum calcium, serum phosphate, ALP, parathyroid hormone, and 25 OHD are the investigations that are suggested. And in all these cases, the 25 OHD, that is the active vitamin compound, will be either normal or in the low normal levels. Parathyroid hormone might be elevated in case of secondary hyperthyroidism. ALP will be high and it reflects increased osteoblastic activity. Serum phosphate will be low and serum calcium will be either low or normal. It will be low in type 1 and type 2 vitamin D dependent rickets, normal in hypophosphatemic rickets. And the other parameters include 1, 25 OH2D. It will be low in vitamin D dependent rickets type 1 because there is a defect in the enzyme level. Whereas in case of vitamin D dependent type 2, it will be high because the problem is at the receptor level. Urine examination, there will be phosphate and bicarbonate wasting in Fanconi. Imaging wrist X-ray shows metaphyseal cupping, fraying, and widening. Additionally, renal function test or genetic test is indicated based on the symptoms and signs. Coming to the management. So first we have to identify the underlying defect, whether it is nutritional rickets, whether it is rickets, and if it is so, whether it is nutritional or whether it is non-nutritional. And if it is non-nutritional, we have to identify the underlying defect, then correct calcium, phosphate, and vitamin D levels, managing the metabolic acidosis and renal dysfunction, preventing any permanent skeletal deformities is the ideal choice or a goal of the treatment. There should be regular mandated follow-up with biochemical monitoring. So specific management for vitamin D dependent rickets type 1, calcitriol 0.25 to 1 microgram per day, calcium 500 to 1000 milligram per day. Vitamin D dependent type 2, there requirement will be a very high dose of calcitriol up to 3 microgram per day because the problem is at the level of receptors and calcium infusions. Hypophosphatemic rickets, that requires oral phosphate 20 to 40 milligram per kg per day, calcitriol 20 to 30 nanogram per kg per day, and burosumab anti-FGF23 for refractive cases. Renal rickets, calcitriol or phosphate binders plus dialysis or renal transplant is suggested. In case of Fanconi, alkali therapy like sodium bicarbonate or citrate with phosphate and vitamin D is required. In case of hypoparathyroidism or pseudo-hypoparathyroidism, there will be requirement for calcium and calcitriol replacement. Coming to the supportive therapy and orthopedic care, physiotherapy to strengthen the muscles, orthopedic management for deformities like splints and surgery, high protein and calcium rich diet. Regular follow-up every 3 to 6 months with a lab and x-rays are required. Coming to the prognosis, it is excellent in case of vitamin D dependent rickets, RTA and Fanconi types with early therapy. Variable in case of vitamin D dependent type 2 rickets and for hypophosphatemic forms, a lifelong therapy may be needed. Poor in case of renal rickets unless renal function is corrected. In case of untreated cases, there will be permanent deformities, stunted growth, and pathological fractures. Early treatment ensures normal growth and bone strength. So, to summarize, there are actually different types of non-nutritional causes like vitamin D dependent type 1, vitamin D dependent type 2, hypophosphatemic, renal rickets, RTA, and hypoparathyroidism. So, the defect lies in the enzyme level in type 1, receptor level in type 2, gene mutation in hypophosphatemic, and chronic renal failure is the reason for renal rickets. Tubular phosphate loss will be there in Fanconi and low or resistant to PTH in case of hypoparathyroidism. So as we have discussed previously, this is how the laboratory reports will look like, and the treatment of choice is this drugs like calcitriol and calcium combination depending upon the cause and the requirement of dialysis. So except for renal rickets which has a guarded prognosis and vitamin D dependent type 2 which has a variable prognosis, all other type of non-nutritional causes have an excellent to good prognosis if detected early and treated early. So the take-home message is non-nutritional rickets occurs despite adequate vitamin D intake. Always suspect in case of poor responders to therapy. Investigate biochemically and treat specifically. Early recognition prevents lifelong deformities and growth failure. I hope you must have learned from this presentation. Thank you.